sono proprio le
No,
sono.
vedi, queste sono le cose. Devi togliere, cioè potevi usare. Non ci metti.
Questa? Sono di
No, ma erano piccole. Queste sono quelle buone. No, l'hai portato. No, com'era? No, no, ma questi non sono cioè sono calciatori, non sono speciali. Quello che almeno quando devi cambiare le schedine non ti passano. Non mi capita.
questi sono
Questo sicuro non è.
cosa inizi nelle direzioni aree.
Eh?
Sei anche bellino.
Dici? Faccio finta che non è detto niente.
Meno male che è trasformato.
Vero?
Sì.
No, perché ci ho pensato quando me ne è andata a trasformare subito.
Analizza mu
Sì, è vero.
e correggere, no, non la correggo.
Arriva da Mac, non è mai passato, non è mai passato su
Perché sì, perché Mac fa crea
Agent
dei
Web
file.
Conference. Sopra la terza.
Conference, dunque
Sì, quella. Vediamo se mi
è
piace.
in quarta sessione o in quinta? Come il cognome? Scusa?
Mariani.
Maria Ilaria, giusto?
Sì. Sì, no.
Allora proviamo su. Tanto qui non esce.
Ok. Sì, messo sulle slide.
Stacco anche la chiavetta così.
Daniel lo chiama nella sua testa.
Il nome lo lascio così, Mariani, Politecnico.
Sì, mi sembrava comodo. Se vuole aggiungere davanti il 7 per
C'è
questo
già
nome
nella
7,
cartella.
allora a posto. Grazie.
Grazie. Invece questa è signor
Apprezzo. Allora, è Smarcher, la cartella Smarcher. Fa ultima modifica.
Ultimo.
Sì, perché eccolo qua. Apprezzo, sì.
Qui ce n'è di più.
Sì. Forse spero che il suo intervento sia quello finale.
No, ma delle volte ho visto delle
Sì, no,
presentazioni
ma-
con 2 slide che sono durate 1 ora e mezza.
Ecco. Ok, c'è tutto. Grazie mille.
Si vede un Mac. Ecco, allora abbiamo provato.
Questa è la cosa peggiore.
La famosa diatriba che va avanti da secoli. Meglio Mac o PC? Da secoli. Infatti ogni volta che si mette chiede di fare una correzione, ma è normale perché ci sono dei file generati.
Allora, si chiama Modern One.
Devi solo aprirlo.
Ah, solo
Per
prima?
tutti i sto scaricando le schede.
Ok. Allora, era il signor?
Caimi, primo.
Lo tolgo, ci fossero dei link. Potenziale sì, questo è. Questo ce l'ha messo Bill Gates perché
Almeno più di 10 anni che non ho computer.
dunque c'erano, infatti non le vede tutti, adesso guardiamo, forse potrebbero essere.
È tutto così.
Delle volte lo fa con JPEG e TIFF perché Mac ha un'estensione uguale ma il contenuto non è del Picture Expert Group. C'è il problema. Beh, diciamo che già il tema del congresso presto riguarderà anche me, però. Ah, qui non mancava niente.
No, così.
Proprio così.
È un po' così, perché si completa normale. Ah,
Torni indietro?
non fa niente, anche se è così. No, questa qua, quella dopo. Sì, va bene, anche se va a casa, a capo non fa niente. Questo l'argomento che è abbastanza...
Morning.
Questa è bianca, non so perché.
È così proprio.
Perché sì. Perché ho deciso di lasciarmi una bianca.
Ah, ok. Sì, l'importante è che non manca qualcosa. Ma questa dura 20 minuti?
Sì.
Va veloce. Da 3 c'era. Che ha delle transizioni molto. Ha dei fade molto lunghi. È giusta?
Sì.
Questa è l'ultima, perfetto. L'unica cosa sì, quando la salva, sì. E poi la torniamo a aprire perché credo che ci dirà ancora la stessa cosa. Questa cosa qui bisognerà farla
Ogni volta.
sì, all'avvio.
Sì, va bene, va bene. Anche se ci sono problemi non so di cosa devo parlare, quindi.
Sì, ma non vorrei, però lo facciamo prestissimo. Please give me your key. Perfetto. Grazie. Questa è la scuola. Un po' di sistema.
Mhm. Mirandola.
Sei a posto?
Sì, sono a posto.
Tomasz Kowska, yes, it's me. Don't worry about it. That's it.
Animation. Good, thank you. Quindi le abbiamo tutte? Max? Puzzo c'è. Garuto. Mannaggia. Me ne manca uno, Max?
Una mattina?
Sì, mi manca Gheno. Ah, questo è uno slide, va bene. E Mariani. Mi manca solo Gheno.
Chi è che ti manca? È largo così? No, è la tua opportunità, scusa. Io non lo conosco lo spagnolo. Guarda, guarda. Ah, lo scarta, non fa. Ah, è vero. È vero. Poi sono più vicino al mondo della vita. Di tanto. Anche ogni 2 settimane.
Fare facce dei registi, capito? I magici.
Ogni immagine.
Ma dopo guarda che impara. Ci pariamo tutti, sai? Dopo imparano.
È un attimo,
In spagnolo in 6 mesi,
Camtasia. Ah, non Camtasia, Cam Studio. Eh, come deve fare questa acquisizione? Da PC con PowerPoint o con cosa? Allora, dunque, aspetta solo un minuto che ti richiamo, che sto provando l'audio di un PC. Ti chiamo fra 2 minuti, ok? Prego, Luca.
Ma mettilo su quell'altro computer. Ah, non c'è il cavetto. Mettilo su watchout. Ah no, tu ce l'hai solo in ingresso.
Hai trovato?
Sì.
Max, se ti colleghi mi dici se ti arriva il suono. Ti arriva in streaming? Ce l'hai? Ok? Ah, italiano. Dunque, Democenter, Prevention, Technology Rettoriale, questo?
Esatto, sì.
Facciamo una prova. Sì, se mai.
L'ho salvato su un PowerPoint normale, spero che sia tutto in ordine.
Tanto lo vediamo solo noi adesso.
All right.
Grazie.
Mission accomplished. Grazie.
Buongiorno, buongiorno a tutti. Scusate. Scusate. Buongiorno, good morning. È un piacere, direi, di cominciare, sono le 10:35. Cominciamo questa seconda giornata sull'Aging Wealth. Il mio nome è Massimo Dominici, sono ricercatore dell'Università di Modena, sono un medico, sono un ematologo, un oncologo e mi occupo attività di ricerca relative all'utilizzo di cellule staminali. Abbiamo programmi che riguardano anche l'invecchiamento. Io penso che il convegno sia in inglese, per cui in questo momento cambiamo lingua. So good morning everybody, my name is Massimo Dominici. I'm going to be the moderator for this morning and this afternoon session. And so when they invited me to speak about aging, I was looking about words which can communicate the importance of having the aging as a focus of this meeting. And one of the words that came up in my mind was the independence. Be independent for elderly is one of the major aspects for a wealthy aging. And be independent is something which is sometimes a simple word, apparently very easy to achieve when you are young, but when you're getting old, these things, you need to have someone which is taking care of you. So technology, social services and system may work together to create and to improve the independence of elderly. And so this is why it's important to dissect each of the single aspects which are related to the independence. And so we have, I'm honored to moderate this session. So we're gonna go through the several pathologies which are related to being independent, and we will gonna decline these topics into the prevention. Okay, prevention is very important, we know, and so I have the pleasure to introduce the first speaker of this morning. He's coming from the University of Montpellier, in University Hospital of Montpellier, is Professor Davide Caimmi. He's going to talk with us about the Airways ICP. So please welcome to the podium.
Thank you. Let me introduce myself. I'm Davide Caimmi. I work in Montpellier, France. I work with Jean Bousquet. I don't know if any of you know him. He is really into this topic that I'm going to talk about today. And what am I going to talk about? Well, Airways ICPs. I have no idea if you all know what ICP is. I basically recently discovered it. But you need to know what it is. So let's find out together. What I'm going to talk about, Airways ICP, Airways, I'm going to talk to you about what chronic respiratory diseases are and why we really need to focus on that. Each one of us surely is interested on his own work, but I'm going to try to convince you to see what we are going to do and what we're going to plan to do. Non-communicable diseases include airways diseases, chronic diseases, and we all know how to treat them in kids. Just a small parenthesis, I'm a pediatrician, so I'm really into kids. But what am I doing here? I will explain to you. When we talk about respiratory diseases, we're talking mainly in elderlies about asthma, cough, and allergic diseases in general, which they show a prevalence which is pretty high. You see, as for asthma, we have more than 300 million people. And non-communicable diseases in general they all have like the same risk factors in common. CVDs, these are cardiovascular diseases, and CRDs. You see most of it, tobacco smoke, it's one of the most important, physical inactivity, and pollution, air pollution. And in general, non-communicable diseases have something else in common, which is very important in chronic respiratory disease as well. As you can see, it's a painful condition, and the patients are depressed and are full of anxiety. So when we think about all the non-communicable diseases and chronic respiratory disease, we have a common pattern. And the European Innovation Partnership on Active and Healthy Aging is helping us, of course, and it's supporting this topic as well. We have Airways ICP, and we can take same model that we did also for, that they did also for cardiovascular diseases and type 2 diabetes. And what we are going to do is actually, well, first of all, we are a reference site. I don't know if any of you have ever been in the region, Languedoc-Roussillon. Just in case, just come visit us. It's a lovely region. And Montpellier is a lovely town, so just to let you know. And as a reference site, we are trying to do our best to promote this program. The risk factors, we all know them. Several risk factors, they're going to lead to what? They're going to lead to an impaired aging. That's not what we want. We all know very well tobacco smoke is one of the major environmental risk factors. But there are other risk factors that have to be considered. So basically, the plan is to work on prevention and control of the disease, of the chronic disease. But we also want to prevent its onset and all the consequences. So why don't we start early in childhood, working to prevent what's going to happen later on during life? So ARES ICPs, we actually published the paper in August this year, explaining you, yeah, you see there are many authors. I see your face. And it's been launched by the NHS in England, in UK, sorry, by Mike Buick recently in February as well. And we have several things to do. So we're not just going to go through the whole thing there. I'm just going to focus on a few of them. First of it, we already know guidelines exist. We're not going to change the world like that. But what we want to do is to think about what single country in Europe has done. So we see, for example, in Finland, that fight asthma can be successful. What did they do? Well, they have a zero tolerance policy on asthma deaths. What that means that they basically have lowered so much asthma-related deaths. So in another country, what they said is like, guess what? In 87, they predicted that the cost for asthma was like 250 or 500 million euros more than it actually is. So we're doing a pretty good job probably. And in Brazil, they lowered the number of hospitalization. So several programs already exist all over the world. In Italy, these programs basically, not for asthma, for cough, to reduce the use of tobacco, smoking. And in Portugal as well. So every single country, every nation has developed some kind of preventive program. We want to put all of this together, and using the WHO approach, we want to have a common approach for the control and the severity of the respiratory disease. So we know pretty much how to get closer to a patient who has asthma, severe asthma. That's something that's been also uniformed by the World Health Organization pretty recently. And once we have known how to do with asthma, we want to enlarge the whole thing on allergic respiratory diseases and COPD. So why? Because most of it, this is kind of confusing. I just will focus on the important thing. Basically, when we do not diagnose asthma, when we do not treat properly, when we do not take care of what the patient does at home, and we don't really explain to him how to deal with this disease, we are putting the patient at risk. So we are going to plan, we already started with that, some meetings to ask to a panel of experts how to deal with these conditions. So for example, when we face someone with asthma or COPD, what are the questions we have to ask ourselves? So our prioritized questions were on asthma, COPD, rhinitis in older people, and comorbidities. And also we vetted pediatric interventions to reduce this comorbidity. So this is just some questions on asthma comorbidities and COPD comorbidities. And then we have the ICPs. Okay, what do? We know allergic diseases and asthma often start before the age of 18, pediatric age. We need to focus on prevention, early diagnosis, the two major points. And we said, well, let's use the ARIA approach. I think most of you are not familiar with ARIA, which is a guidelines on allergic rhinitis and asthma. And it's been redone by the GRADE system. It's a pretty good guidelines, let me tell you that. It's been published in several languages. And in the 2010 revision, we have plenty of papers that talk about ARIA. And it's been, several analyses have been done over this kind of guideline. And in a paper in 2013, seems like, as you can see there, ARIA is pretty much the best one. As for scope and purposes, clarity of presentation, and applicability. So we need to use this system to create ICPs. And what do? ICP are not guidelines. ICP are made by a multidisciplinary teams. They're not just allergists. They're not just respiratory experts. And basically are guidelines that are put into the real world. We want to see what happens when you do it in real world, how you change your attitude toward each single patient. And every alteration has to be included in the ICP. So the same thing, we're going to do it with ARIA. And every variation has to be included. And the two major things is like, that's what comes out from ARIA. If you have rhinitis, look for asthma. The same thing. If you have asthma, look for rhinitis. But how do we control these single patients? You know, I don't know if you know, there are like systems that tells you, you know, this week you're going to have a lot of grass coming out and you're going to sneeze. Well, that's kind of cool to do. But we have to have a real sentinel that it's developed by patients themselves. That's what we thought about. How do we do? Well, each patient just gives us a text through our system that tells us, you know, today I'm sneezing. I'm allergic to, I don't know, to grass. And today I'm sneezing more than usual. Well, that works much better than counting the pollens in the air because it's the real symptom presented by the patient. And once we do that, we can alert the other patient who have the same symptom, you know, in your area, the allergen is going to be higher this week. So basically, it's one of the many approach through applications for cell phones. And it all's based on the visual analog scale. So the patient says how much he's bothered by the allergies. The same thing we can do then with COPD, with a list of prioritized questions for people, for elder people. And what are the questions we can ask to these people? First of all, I don't really know how many of you are doctors, and also I told you I'm a pediatrician, so I don't really understand that. But I don't never really understand, I don't see a huge difference between cough and asthma in old people. I see when I just really talk to them, but when I really see the patient and he talks to me about his symptoms, I don't know, do you really see a difference? It's kind of difficult. You have to go really deep. And how deep? And what kind of question you have to ask? And about all the drugs that people take, especially elderly. And then once we've done all of this, we have to just spread out the word. How do you do that? I told you about Mike Buick in February, and it's a list of things to do. Like MOH in Rome was like on Tuesday and Wednesday. The EIP for the reference site of Montpellier will be on Monday and Tuesday next week, and we're just going up. And we have plenty of meetings to just see people and see what people can do and what we think we could do to just like move on and just not be stuck just with the rhinitis, which is like what I'm going to be focusing on. So I really like that project, but to enlarge the whole project. And well, that's what we had this week, in Rome. And then the whole goal is like to just do what the WHO told us to do. So there are targets for 2025 and an action plans with 6 different objectives. And so we have for non-communicable diseases, we have to increase the prevention and the control of symptoms. At the same time, we have to focus on national capacity, leadership, governance, to give a response to these kind of questions to prevent and control non-communicable diseases. We have to eliminate, possibly, modifiable risk factors. Well, of course, tobacco smoke is the first one. And we have to push, let's say that, healthcare system to do the best to prevent and control non-communicable diseases. And for a universal health coverage, we have to support national capacity of high-quality research and to monitor the trends and determinants of NCDs and evaluate the progress we're doing. So, globally talking, ICPs, it's a real translation of guidelines in clinical practice. It's focused on the patients. It's not focused on the MDs or any other member of the team. It's a multidisciplinary approach to the patient. And it's a really, it puts the subjective into the standard. So the patient in front, the doctor in front of the patient, that's the subjective part. That's where we try to follow the guidelines and try to put the patient in the right place, and we change the guidelines following what the patient needs. So the project will achieve the objective of an active aging and for the early diagnosis and treatment of chronic diseases as early as possible. That's why I'm into the project as well. And healthy, to improve healthy life years and reduce burden, while at the same time improve quality of life worldwide and to reduce the disease incidence. So basically that's the project that we are trying to do on airways, so on respiratory diseases, and that's what we hope we're going to achieve by 2020. Thank you.
Thank you very much for the presentation. I think we're gonna move the questions, the round table. If there's any burning question for Dr. Caimi, we can take one single. Otherwise, we're gonna use the round table to discuss the presentation. Okay, thank you very much. So it's time for a second speaker for this morning. Is prevention in cardiovascular diseases. Is Dr. Kotska from the University of Lodz. So please welcome. And cardiovascular diseases, is a preeminent cause of death. So prevention in this case is very important and is going to interest certainly the majority of the people in the Western world. So.
Thank you very much for invitation. I'm really proud and honored to be here. I'm going to talk about prevention of cardiovascular diseases. I represent here also my Medical University of Łódź. It's just in the middle of Poland. And Healthy Aging Research Center, which is a RECPOT European Union project currently run at our university. So first of all, I will focus shortly on epidemiology of cardiovascular diseases, then I will talk about prevention of cardiovascular diseases in general population, and then I will focus on particularities of prevention of cardiovascular diseases in older people. Here we can see population pyramid of Poland. In just 30 years, this population pyramid is going to change dramatically. During the last 25 years after socio-economic transition, average lifespan in Poland increased more than 6 years, both in men and in women. So we face really very important challenge of aging society in all Central European countries. Cardiovascular diseases are the main cause of mortality in European Union. Coronary heart disease, stroke, and other cardiovascular diseases constitute almost half of mortality in European countries, both in men, even more in women. So it is still the most important health problem. How can we prevent cardiovascular disease? What are the main guidelines to prevent the spread of cardiovascular diseases? We concentrate on risk factors of cardiovascular diseases, which are shown here. The main risk factors are diet, smoking, family history, lipids, glucose, blood pressure, anthropometric data, body mass index, waist-to-hip ratio, and other laboratory measurements. These are the main cardiovascular risk factors that should be considered in prevention of cardiovascular diseases. The majority of them also is important in other chronic diseases. This is the score system which assess the risk of cardiovascular diseases. This risk is different in men and women, increases with age, is higher in smokers, increases with higher cholesterol level and higher blood pressure level. This score system is now divided into two regions: high risk countries in Europe. These are mainly Central European countries, and low risk regions of Europe, Southern and Western Europe. Current guidelines on prevention of cardiovascular diseases were launched during European Society of Cardiology Congress 2012 in Munich in Germany. And those guidelines tackle the most important measure we should undertake to prevent cardiovascular diseases. Those measures include behavioral changes, lifestyle, smoking prevention and smoking cessation. Guidelines regarding nutrition are very well known. They are based on Mediterranean diet, so I just show them very shortly. Guidelines regarding body weight. Here I will stop just for a minute, because in general population we can see that all-cause mortality is lower with the body mass index between 20 and 25. I will point to this suggestion later on, whether is it true in elderly population. Physical activity, all people should engage in regular physical activity 3 to 5 hours per week, depending on the intensity of this physical activity. Management of psychosocial factor, how should we couple with the stress? And major new key messages concerning the most important risk factor. Risk factors are that we should target blood pressure to be lower than 140 and 90 systolic and diastolic blood pressure. Diabetes mellitus and glucose level should be taken under control. So-called glycated hemoglobin should be below 7%. And blood lipids, especially so-called bad LDL cholesterol, should be low, especially in high-risk patients. In secondary prevention, we use antithrombotic therapy with different drugs. And now I will move to the prevention of cardiovascular diseases in the elderly. Is it the same or is it a bit different? Here we've got the data as an example of one of our recent studies in Polish population. We can see that ischemic heart disease, the prevalence is more than 30%, independent of the living condition in urban, rural, or institution environment. Hypertension, about 60% of all the people are hypertensive, not only in Poland, in Italy, in France too. Chronic heart failure, especially high prevalence in nursing homes. More than 10% are post-MI after myocardial infarction patients. About 10% on the average are post-stroke patients. The prevalence of diabetes is about 20% in all the population. So cardiovascular or cardiometabolic disease is usually present in our older patients we deal with. Current cardiovascular diseases risk profile assessment tools consider more than 10-year risk in young or middle-aged subjects, and this middle-age risk usually evolves to a high risk in an older individual when we use current measures. Furthermore, currently available risk prediction tools are valid up till certain age, usually till 65 or sometimes a little bit more. So the most important risk estimation tools like Framingham score or the most important score system are usually valid till the age of usually 65, sometimes a little bit more. And given we have many millions of people in Europe that are 80 or 90, this system doesn't work there. Here is an example of one of the most important studies published during recent year, Interheart study, when we can see the differences of odds ratio of the risk of myocardial infarction in patients older and younger than 60 years. We can see differences in almost every risk factor. The most important are that hypertension, smoking, dyslipidemia, and diabetes remain significant risk factors for myocardial infarction in the people aged more than 60 years old. Conversely, especially in men aged 60 years or more, moderate alcohol consumption and physical activity become more important protective factors. What is especially concerning alcohol consumption, good news anyway. Several recent studies have shown a significant improvement in discrimination of risk estimation when we use specific biomarkers, including interleukins, C-reactive protein, troponin, brain-naturated peptides, cystatin, or carotic plaque burden. So when we use these new substances to discriminate risk in older people, like homocysteine, folic acid, or C-reactive protein, we can discriminate the risk better than in the younger population. Those new indices of or potential new indices of cardiovascular risk are not included really in the guidelines, but European Society of Cardiology states that the use of some of them may be considered, and they may be used as an additional risk factor assessment tools. Especially C-reactive protein, it's an interesting example because it is a marker of inflammation in our body. And C-reactive protein increases during inflammatory diseases, which are very common in older age. And only recently, there are few studies that started to deal with the relationship between cardiovascular diseases, inflammatory markers, and real geriatric syndromes like frailty syndrome, sarcopenia. Those syndromes that are related closely with disability, which is probably the most important target in older population. Not the diseases themselves, but disability. We can function pretty well with several diseases when we are capable to do basic activities of daily living. And those factor inflammatory measures like C-reactive protein or interleukins are new markers, and conventional risk scores perform unsatisfactorily in older people. We should consider use those new markers. There's an example, one of study of our center, when we have compared the sign of subclinical atherosclerosis to the physical activity in real life. And we can see that physical activity when we are younger or middle age has very strong relationship with our atherosclerosis status when we are older. Coronary artery calcification, carotid intima media thickness is lower, and the reactivity of the vessel is better when we were physically active in our middle ages. So the accuracy of risk estimation has been generally shown to be substantially lower in older persons than in middle-aged people. And better risk estimation in older people will only be partially solved if we use cardiovascular disease prevention tools. Other aspects should be considered, like what level to consider as high risk, because when we use, for example, the SCORE, the most known rating system, almost all people who are older will have a very high risks, and should 10%, which is considered as high risk, should be considered also high risk in older people. There are several studies who have shown that we can influence risk factor even in older population. Here is very known HIVET study published a couple of years ago in people aged 80 years and more, when lowering blood pressure had a beneficial impact on overall and cardiovascular mortality. The same with lowering cholesterol level in older population. We have now data indicating that yes, we should consider lowering LDL cholesterol even in very old people. But although the recent randomized controlled trials of preventive measures in older and even very old people have demonstrated that significant benefit can be achieved, it is still uncertain whether risk stratification can assist in targeting this measure towards those who will benefit most, and if so, what threshold is appropriate in this age group. And whether we should concentrate on disease-specific or overall health approach. Evidence-based approaches work in discrete conditions, not in individuals with multiple disease. And treating the disease may not be always good for the patient with multiple conditions. I was very glad to hear yesterday that we are moving from paying per service to more holistic approach. For example, general overweight and general and abdominal obesity are independently associated with an increased risk of heart failure. It is very well known. More obesity, more heart failure, but more obesity in real life, because there are now several studies that have shown that in really older population, the best survival is with body mass index between 28 and 30. There are several studies that have shown that mortality was lowest for overweight patients in older population. So overweight should not be a problem when we get older. In very elderly subjects, even with diabetes mellitus, increased body mass index was associated with reduced mortality risk. So single disease model should not be applied to preventive measure in older people, and we should identify factors which may affect quality or quantity of life in this population. In geriatric population, we cannot discern between risk factor and diseases, between prevention and treatment. We treat hypertension, we prevent heart failure at the same time. So the main conclusion from my short speech are as follows. When we talk about prevention of cardiovascular diseases in the elderly, we should keep in mind that usually cardiovascular disease is already there. Several cardiovascular disease risk factors are usually existing or coexisting. Prevention should be integrated with treatment, and overall health approach is needed. We should not combat single diseases. We know very well from several studies, for example, in diabetes, that lowering too much blood glucose level have led to increase in mortality. Why? Because too low glucose level made older people to fall more frequently and increase mortality. Thank you for your attention.
Thank you very much for the presentation outlining the importance of simple things which we can do in our day life to prevent diseases. Even in this case, we're going to discuss this in the round table. So thank you very much again. So it's now time for Dr. Gianmatteo Apuzzo. He's going to speak with the project Smart Care and Regional Strategy for Integrated Cares. It's coming from Trieste, so from Italy.
Yeah. Okay. Thank you. Good morning, everybody. Thank you for inviting me. I think this is a very good opportunity to discuss on topics we are facing commonly and to meet also friends and colleagues. I'm currently working as project manager of EU-funded projects for the Friuli Venezia Giulia region. I am a project manager and I am an urban sociologist. Sorry for that. And so I'm not going to present very technical and clinical aspects as the previous speakers, but I'm going to present more a process of integrated care. And I come from the Friuli Venezia Giulia region that is one of the oldest regions in Europe. The percentage of over 65 is around 25%. And in city like Trieste, where I live, is already 28% the percentage. So the region has set up already a system for integrated care. And what I would like to present in this process is that we have a good tradition of integrated care, but so far is not supported by ICT. That's why we have a lot of initiatives, experience, and I'm going to show you also some projects that anticipated smart care, but no ICT supported. So as you can see, we have this integrated care model based on regional initiatives and also national initiatives. So the region has just approved a big health reform, a reform health system 2 weeks ago. So it is going also to strengthen this kind of approach for integrated care. The community-based care, home care, and the chronic disease as the main topic of the social health care, less than the acute event and the hospitalization. And of course, the last point at the bottom of this slide is that integrated care is not just social and health care, but it is to integrate with the innovation policies and housing policies. About pilots and experimentation that we had so far, so we try to put technology and ICT innovation in this tradition, this health and social care. So we have some regional initiatives, that is the ones you can see in the slide. We have a regional innovation law with a specific article on welfare, innovation in the welfare that funded several projects on domotics, automation, accessibility. We have a strategic project about accessibility, home care, and innovation. And we have now a regional cluster on technology for ambient of life that is based on the national cluster that has the same topic. And also at the international level, European level, we have tried to put some funds, of course, and also some pilots experimentation to strengthen this process. So we are in the European Innovation Partnership for Active Healthy Aging, in the G4 group about age-friendly cities. And we had other cooperation territorial project like HELPS in the Central Europe program and CASA, funded by Interreg 4C program. A previous ICT project that was dreaming, that was specifically telemedicine and not integrated care, not so much as smart care. So the challenge that we have, and I think that some of the speakers yesterday already mentioned it, is to pass from pilots to policies, from pilots to practices. And of course, this is what we are trying to do in our region also through the Smart Care Project. So the Smart Care Project is to pass from usual care to integrated care supported by ICT. As you can see, of course, there are healthcare and social care that have to be integrated better than as they are, and also the empowerment of citizens, of patients, and of informal carers as well, with the self-management and self-help practices. We are involving in the project 24 regions and other many institutions like users, organization and users representatives. And just to go, because then I will repeat some of the hints that you had in this slide. Okay, this is the former slide of Smart Care that I had to put in the presentation. Of course, it is a 3 years program, ICT PSP, Pilota, with support policy program. So this is the main objective. It's not just to experiment ICT, but to strengthen and support policy implementation. So, Smart Care is not an ICT project, it's an integrated care process enabled by ICT. We are running 9 deployment sites, I'm not going to present the results, just some lessons learned so far at the end of the presentation, because now in these days, in these weeks, the deployment site is starting their concrete deployment. So we had a lot of work, of course, about methodology, about operational protocol, and about the operational plan to start the deployment. And these weeks we have 2 regions that already started. It is Aragona in Spain and South Denmark. And Scotland and Friuli-Venezia Giulia is starting in these days, and there are other 5 regions starting now. Of course, the aim is also to clarify potential models for integrated care. So this is, of course, one of the goals to support the policies. I think that we had already seen this slide yesterday presented by Bridget, so it is just a picture of what I'm trying to present you. So I would like to go to the next ones, because I don't want to run in over time. And the main point is that ICT is not the goal. ICT is an instrument, a tool to enable integrated service. So the point is to have organizational model, subsequent action, supported by ICT where reasonable. Not always, but where reasonable. And of course, the integration needs the involvement of end users. So we put a lot of attention on this aspect, involving, as I've already said, and users board, and also the end users. So the requirement of end users, older people, informal care, professionals, and and representative of user support. So this is the picture, the global picture of what we are trying to do in the project. So, of course, we have a manager structure, we have a user advisory board, we have committed regions. So, as you can see, we have 9 pilot regions, 9 deployment sites, and we have other committed regions that are trying to be involved, to keep some lesson learned, and to try to develop in the region what is developed in Smart Care project. Of course, the program is not just pilot service specification, but building blocks of all the action needed from ICT to organizational model for the integrated care. And of course, we will have a final evaluation of the work we will implement. So what we are expecting as shared outputs in the partnership. Of course, integrated care pathways validated with service model and a value chain. So this will be the main aspect of the validation of these integrated care pathways. Of course, a common ICT integration infrastructure architecture. This is one of the points that maybe is more challenging, because when you have a lot of pilots in a region, in a territory, you risk to have also a fragmentation of technology. This is one of the points that, for example, we have in our region. As you will see, we had several projects implemented in the previous years, and we have different technologies in different pilots. So the point is also to have this integrated common ICT integration infrastructure. Of course, operational guidance, as the previous speaker said, there are a lot of guidelines. What we are trying to do is to support region with the operational plan to start deployment of integrated care. Of course, I focus on sustainable business. A cost efficiency study will be implemented during the deployment size, and also a consensus building, how the change management can support the regions, the territory on integrated care to find a consensus. And the last one is the contribution to European Innovation Partnership, right, the B3 group on integrated care, and the European Commission in asking Smart Care to have this focus to support the European policies. So what we are expecting from ICT, as I've said, is not an ICT project, but ICT is really important. And the role of ICT is to support the care coordination, of course. There are silos that is often divided, so to go beyond silos through the ICT. The information sharing, of course, the integrated and multidimensional and joint assessment also through the ICT support, and also, of course, the empowerment of citizens and patients and care recipients with the technology for self-care and self-management. So it's not so clear maybe, but this also yesterday was already presented, but this is the, we will have two pathways for the experimentation. One is the long-term pathways, and one is the post-discharge pathway. This is the long-term pathways. Of course, you have entry points, and in this case, it is divided, the entry points, because it could be a social care entry points or healthcare entry points. For example, in Friuli Venezia Giulia, we have a unique entry point because we have already an integrated assessment of social and care needs in the local health districts in the territory. So there is an assessment for the enrollment in smart care, and then when a citizen, a patient is enrolled, of course, there is this multidimensional assessment for the health and social care plan. Then there is a personalized provision of care that is in the center of this slide, and then, of course, all the evaluation and living point. This is the hospital discharge support that is more or less the same. Of course, the entry point is different because it's in the hospital where we are trying to set up an integrated care assessment for after discharge for the continuity of care. This is some figures and numbers that are foreseen in the different deployment sites. As you can see, there are different regions, and we have Attica in Greece, South Karelia in Finland, North Brabant in the Netherlands, Uppsala, they are 10, but Uppsala has withdrawn, and now there are 9, and Kraljevo in Serbia, so we can also compare the system in a pre-accession country like Serbia. If I have just 1 minute and a half more, I would like to present what we are doing in Friuli Venezia Giulia. So this is our deployment sites about integrated care models, focus on primary care and more focus on cardiovascular disease. We will have 200 patients enrolled. We have finished right now the testing phase, and as you maybe the Italian were present in this room knows we are a long-lasting process for all bureaucratic aspects, and of course we are waiting next week the approval, the final approval of ethical committee, and now we are going to start in the next weeks the concrete deployment. What is really important is that we have already involved in the management team, but also in the regional territory, healthcare, social care, and third sectors, and also informal care. So the target population has over 65, cardiovascular disease mainly, but also diabetes mellitus, and also some kind of frailty from a social aspect. So we will have, of course, a randomized study, randomized control. We will have an intervention group and a control group, and the enrolled patient will be divided in these two groups. And this is a scheme, a very simple scheme on what we are going to implement in our region. So there are the control group that will receive the care as usual, nothing more and nothing less, of course, and an intervention group that will receive a continuous monitoring. We will have, of course, an electronic platform, we will have devices at home, and we will have a call center for managing the alarms and managing the data. So, the last slide, some lessons learned so far. As I said, I can't present results, but some lessons learned in this preparation phase I can share with you. Of course, maybe the first one is quite obvious, but is not obvious sometimes also for the European Commission, maybe, because Europe can seem as one, but there are very differences still in Europe. So differences in government organization, governance, in funding, instrumenting, financing, but also in providers' responsibility. It's sometimes also difficult to say what is social care and what is healthcare, because in some countries you have health providers that provide also social care. So this is a huge difference. When you have to think about how to implement integrated care, it's not just to focus on care issues, ICT issues, but you have to have a vision about that and to have a model based on the vision. But it's also not simply goodwill, because sometimes you have some people very well involved and very well committed that implement personally a very good experiment, but it is not only that. You still need organization, you still need structure, and of course you need leadership in this innovation. Sometimes when you try to change something, you just move from one location to another, the care just move from hospital to territory, but it's not the case when it's not to just move the location, but is to reorganize and to redesign the services. As yesterday we have already listened to, there is a big cultural issue. There are barriers, constraints to change, and so of course a change management support, it is really, really helpful to support this kind of changes. And the last one is what we have learned so far about the difficult process to implement this innovation, that technology is not the issue. Of course, I'm not saying that technology has not some big issues to solve. Yesterday, Bridget presented the interoperability, of course. But when a region tries to change its system, you discover that technology is already there. You have to put in practice technology, pass from technology to practices, to policies. You have a lot of technology that can already help what you are in your vision. For example, we had a 7-month lasting public procurement process for ICT provision. So if you can understand, 7 months process is very huge amount of time that is risking to stop everything. So of course you have to put in the focus the actions, initiatives to face all these problems, and maybe technology we will help you at the end, but it is not the issue. Thank you very much.
Thank you very much, Dr. Apuzzo, for the presentation. So it's time for Dr. Garuti from ASL Reggio Emilia. He will, from Italy, so he will discuss about the previous experience and needs and expectation from public bodies. So please welcome.
Thank you. I thank the organizing committee for the invitation. I thank the Dr. Lusuardi for helping on my discussion. My discussion is centered on the telemedicine for the prevention of the complication of chronic diseases. Particularly, before to enter in the topic of presentation, we need to see why chronic disease has a great impact on healthcare utilization. Chronic disease are the most common, costly, preventable of all health problems in the world. Particularly, there are many reasons for focusing on the management of these diseases, because these diseases are highly prevalent, are predicted to increase substantially in the next future, are costly, and they are potentially manageable via telemedicine. There are many studies on the impact of chronic disease in the healthcare resource utilization. In USA, 50% of adults have one chronic illness, and the 70% of all health care expenditure are spent on chronic diseases. There are a combination of factors for treating this problem, because there is a demographic composition of population, and this combination is changing. There are advances in medical science, there are advances in ICT, and there is a fragmentation of care and healthcare research and utilizations. A system that could promise to involve patients in their care, provides continuous monitoring, and identify early symptoms and respond promptly to exacerbation, should be considered and assessed. Telemedicine enter in this system because telemedicine can support patients in self-management, provides continuous monitoring by healthcare providers, and could identify early symptoms of exacerbations. Tertiary prevention is the prevention of the damage caused by chronic disease. Particularly, tertiary prevention is centered on exacerbation and is centered on the rehabilitation of chronic diseases. I am pulmonologist and I take care patients with chronic disease, particularly COPD, chronic obstructive pulmonary diseases, and chronic respiratory failure. COPD is a common disease in this century. Particularly, COPD is one of major cause of disability and death in the world. It is estimated to affect about 10% of population. COPD is the primary contributor to mortality caused by chronic lower respiratory tract diseases. And there are many studies on the analysis of cost of COPD. In this study of Miravilites appeared on chest in 2002, Miravilites and co-workers analyzed the cost of COPD. The cost of COPD is divided in two groups. One for the management daily of COPD, and one of the management of exacerbation of COPD. We can observe that the major cost of healthcare research utilization is due to acute respiratory failure and due to hospitalization of COPD exacerbations. In one study appeared in 2004, the I study, an Italian study, this study analyzed the cost of hospitalization caused by COPD exacerbation. The single cost of one hospitalization is about €3,000. Telemedicine could be entered in this system because telemedicine has two important activities for COPD. First, the monitoring of lung function of the patients. Second, teleconsultation between primary care providers, example, general practitioner, and pulmonary specialists. In this study, performed by Vitacca and Maugeri Foundation, the researchers found that a telemonitoring of patients affected by chronic respiratory failure could reduce hospitalization, urgent call to general practitioner, and reduce acute exacerbation. If in the group of patients we divide COPD patients, we can observe that COPD patients seem to have a greater advantage from teleassistance. This similar study, performed in 2012, is observed that COPD patients telemonitored could be treated at home, and the admission to hospital are reduced. But are reduced the costs of hospitalization respect the control group. Another feature of this of telemedicine on the management of COPD is the prediction of exacerbation. In this recent study, appears in 2014, we can observe that a system of telemonitoring at home associated on the monitoring of health status of this patient could predict COPD exacerbation early with a margin about of 5 days. Telemonitoring and telerehabilitation are a great combination for treatment of COPD and chronic respiratory failure. This study observed that the system of telemedicine associated to remote observation of pulmonary rehabilitation program could improve quality of life of COPD patients and reduce days of hospitalization for COPD. Another big chapter in chronic respiratory failure is the chapter of neuromuscular diseases. Neuromuscular diseases are varying diseases, and chronic respiratory failure and acute respiratory failure are very dramatic events. In particularly, two diseases, Duchenne dystrophy and muscular dystrophy, and amyotrophic lateral sclerosis, have a big impact on healthcare research utilization. In this study, appeared in 2010, we can observe that the telemedicine performed on the ILS patients in non-invasive ventilation could decrease healthcare utilization, particularly decrease emergency room visit and hospital admission. The chapter of pulmonary rehabilitation at home is great, is wide. And this study, performed by Vitacca and Maugeri Foundation, showed that a system combined with telemedicine and pulmonary rehabilitation on demand in patient with amyotrophic lateral sclerosis could reduce healthcare research utilization and the hospital admissions. But not only. Telemedicine feel the patient better because in the study of this same system of Vitaka, the patients were extremely satisfied with the nursing assistance, and the program was considered to very good by the patients. In our experience, we perform a telemedicine system in neuromuscular disease, particularly Duchenne muscular dystrophy. In 2010, a joint venture with Santa Maria Nuova Hospital of Reggio Emilia, San Sebastiano Hospital and Local Health Trust of Reggio Emilia, and Italian Union Against Muscular Dystrophy, built a telesystem for patients affected by neuromuscular disease. This system consists in monitoring the oxygen saturation of the patient, and in a questionnaire with quality of life of the patient and health status. These data are sent to a center, a telecare provider, and this telecare provider insert the data in a risk chart, and the risk chart is built in 3 zones: green zone, yellow zone, and red zone. Green zone means that the patient, the health status of the patient is good. The yellow zone, the health status of the patient is near exacerbation. Red zone, the health status of the patient is exacerbated. The data are sent to hospital specialists, and the specialist, when the patient is in yellow zone, calls the general practitioner of the patient and the respiratory therapist. Medical and physical intervention are performed. Physical intervention consists in the use of mechanical cough machine, and if the patient is in the red zone, we have 2 ways. One, the direct hospitalization if it is preventable, or the visit at home by the hospital specialist or in the hospital. This system is not built for the emergency. The emergency is treated by the local emergency system. Our data were published in 2013, and we showed that in 2 years had a decrease of hospital admission and emergency room admissions. Particularly, we obtained a reduction of days of hospitalizations and of days of exacerbations. In conclusion, the number of patients with chronic respiratory disease being managed at home is increasing. Home telemonitoring is an innovative approach which facilitates patient management at home, and telemedicine could facilitate information exchange between patient and the healthcare provider. For the future, home telemonitoring telemedicine intervention still need to be adjusted to ensure their suitability to the target population. Home telemonitoring intervention for COPD should be considered the inclusion of easy-to-use technology. The impact of telemonitoring should be explored. I thank for the attention.
So thank you, Dr. Garuti, for the presentation, for sharing this model. We're going to discuss that later on. So it's time for the last speaker for the plenary session here, Ms. Dr. Ilenia Gano from AGE. She's going to share with us a talk on independent lifestyles and integrated for elderly.
Thank you, everybody, and thanks especially to the Democenter team that for the invite, of course, and for having taken care so well about us in this conference. My name is Ilenia, and I'm here on behalf of Age Platform Europe, and I've been asked to talk about the issues of independent living and aging from the perspective of an older person's organization advocating for the needs and concerns of seniors in Europe. And I've decided to tackle the key issue of prevention from a kind of complementary vision for what we have learned today. And it is indeed through our lessons learned through policies and projects. First, I just wanted to briefly introduce Age Platform, which is an umbrella organization gathering 150 members, associations dealing, working for older people or of older persons in Europe, in the 28 EU member countries. And our mission is to bring older people's point of view in the European policy debates. And we do that, of course, by consulting with our members and by involving them directly through different task forces. We have 14 task forces, but our experts are called to contribute to the development and the monitoring of policies. We want to raise awareness of what are the needs and the concerns of older persons, and we want to especially involve them directly and to listen to their voice through the projects, of course, when we try to involve them through advisory boards or through user forum, and also at policy level, where our members and experts are involved in EU campaigns, for instance, on solidarity between generations, on age-friendly environments, and on the re-establishment of the intergroup on aging at the European Parliament. And last but not least, of course, in Brussels, we are not working alone. Luckily, we are pooling with other NGOs that are sharing some concerns with us, and especially with the disability movement, with whom we share the motto, nothing for us without us. Again. And of course, we have been hearing and listening about aging throughout 2 days, two intense days. And the question for me is always the same. Well, who is old? Well, there is no surprise to the fact that we all are aging since we are born. And it's a real challenge to define what are the needs of an aging population. I like very much this quote from an ex-expert of ours, Angela Cruzel, who was stating that older people are a totally heterogeneous group, and this is a vital point to learn. You have those who continue to decide on their daily living, and those who at the same time have given up. You have those who will grasp the telecontrol and flick through the channels, and those who will leave it in the drawer, preferring to push the button. And I don't know if you recall a Beatles song, When I'm 64. If you just recall the lyrics, I will not sing, I promise, it will be funny to understand how the perspective has really changed on aging. The lyrics present some of the wishes of a person aged 64, according to the Beatles. And if you go through it, you will see how anachronistic, in a sense, it is, how different the perspective nowadays is. And so we are not just dealing with different concerns about a wide aging population, but also of different perspectives in times and in space. And I thought that I could focus on prevention from a different perspective here. Tackling prevention from us is also to co-create, to involve the users, to empower them, and to do things with them, consulting people. Co-create is also mobilizing. Co-create is, of course, also research, and I would like to go through this. Indeed, prevention means also to co-design issues, to involve, as I said, the users. The goal is indeed to create services and products that can be accessible, can be mainstream, can be tailored to the needs of the senior citizens. But on the other hand side, it's also important that the market produces something that is acceptable by the users. And indeed, through the involvement, we can tackle both challenges. But prevention is also to advocate. Prevention is also to try to break the silos, try to push for a more comprehensive approach on aging. And what we are trying to do at European level is indeed to shape the European agenda towards these issues through the European Year 2012 on active and healthy aging and on solidarity between generations, through the involvement in the European Innovation Partnership on Active and Healthy Aging, and we have learned that some other stakeholders are involved in that, and through the re-establishment, for instance, of the European Parliament Intergroup on Aging and Solidarity between Generations, for which we have campaigned till the 22, because the intergroups are to be decided next week in October. And this is key for us, indeed, if we want to move forward and to be effective, especially at European level. Prevention is also to establish age-friendly environments. We have been hearing about environments in several of the presentations before. And with that particular regard, AGE is leading a consortium of a thematic network called EIFE InnovNet, which is Age-Friendly Environment Innovative Solutions. And with the consortium and the network, we work for developing some methodologies that can enable local authorities to assess what is the impact of measures for age-friendly environments, but as well as to allow the sharing of experiences and to go towards the effective implementation of solutions, not just something that stays in the paper and then everybody tends to forget after a few years. The idea would be at the end to launch a covenant on demographic change, and that will be the final outcome of the EIFE InnovNet project. And the goal is to be reached by the end of 2015. The project has started in February this year. Prevention is also, as I said, to mobilize the stakeholders, and this is what we are trying to do through the EIFE InnovNet thematic network. There are 29 partners already involved, coming from 16 different member states, encompasses 6 regions and 13 cities, and that of course have the contribution of other partners, not only local and regional authorities, but also research centers, consultancy, communication agency, European network, and we have the strong support of the WHO, because of course we are working for aligning the WHO guidelines for age-friendly cities and to set up European guidelines for age-friendly environments, and we're working also with the Eurofound. But besides that, even before we were submitting the proposal to the Commission, we were able to gather 40 other associated partners that wanted to join, but unfortunately the consortium had to be closed at a certain step. And it's still possible to contribute and to move on. Indeed, everybody has a role to play, everybody has something to share. Also bad practices, because we can learn a lot from the mistakes that we have been doing from the past. And it's not just to join the network for the sake of joining, but it's to join the network for being informing, but also to be able to comment and to be able to bring a different perspective and to move forward. We are doing that. We are trying to involve the network and the different stakeholders through various channels. One of the most powerful we have experienced is the use of webinars. where we interact directly with the people who are involved and with the people who want to have a say or just want to follow up what's happening. And the next one, if you're interested, will happen on the 19th of November, and it will be dealing with the funds available for age-friendly initiatives. And last but not least, prevention is also research. Of course, we cannot neglect research, and we have been discussing about research this morning, and I guess also yesterday. Apologies, I couldn't make it for yesterday. For me, what I thought it was important here to state, worth to be presented, is the Do-Re-Mi project. AGE is involved in about 20 different European projects in which we are trying to involve other persons at the one hand side, but also to raise awareness of what European research is funding. And with the Do-Re-Mi, I think it's relevant for you to know, because this project really works on prevention. And it studies the early signs of unhealthy dietary habits, of sedentariness, of cognitive decline, which are the main causes of premature death and diseases. And a group of older participants is taking part in pilot studies in Italy and in the UK, where they are participating and they are introduced to food intake measurements. I cannot close this. Personalized metabolic control, exergames, and trainings. And it is indeed by recording the lifestyle changes that we can then provide early warning signs. And here I brought with me the first newsletter of the project. I brought some copies and some brochures in the poster session you will see. And there we summed up the achievements of the first 6 months of the project. And we will do surely more in the next months, because we are planning to start up an online user community. And we would like to test some of the games, also of course in prototype versions, directly online. So if you want to have a taste of the experience once back home, you're more than welcome. And last but not least, prevention is also to make others aware, and so to disseminate. And here I thought it was worthwhile to mention the iVisio project, because the goal of iVisio is indeed to enhance the visibility of European research. What we have been doing so far is to analyze the assets and barriers of some ICT-oriented European research. And we would like now to build synergies among them, to cluster them, and to allow them to interact, to overcome solutions, and at the end, to overcome barriers. And at the end, we would like to address to European Commission what are really recommendations for future research, in order, as I said before, to learn from the mistakes we have done in the past and try to not reinvent the wheel or reiterate the same mistakes. And for that, iVisio has been dealing with 3 trainings so far, and a couple of them are also ahead of us. All the material is available on the website, and you will be able to have a look to the trainings on communication, which was the first, on exploitation and validation of result, which was the second, and the last one on the business canvas modeling. Indeed, to move forwards and to try to avoid to stick to the research bubble and try to go beyond and to reach the market. So this is all from my side, and if there are any questions, I'm available afterwards and also during the breaks. Thank you.
Thank you very much. So thank you very much for sharing all these projects going on in aging. So we are a few minutes before the schedule, so which is very good. So I would like to invite all the speakers of the session on the table here, and we're going to have the time for round table, and then I would like to invite Lucia Pannese from Imaginary and Ilaria Mariani from Images. I think we have some regret, and Francesca Corrado is not here. Okay, And so please welcome Lucia and Ilaria to the table. Maybe we need some more chairs, please. Are we all set? So I think we have, it was just trying to summarize the morning and all these very interesting talks we have heard, and I think we were talking about prevention, and I think we have touched the major aspect of prevention. There are at least, the well-recognized levels of prevention. We have three types of prevention. We have primary prevention, we have secondary, and we have a third level of prevention. And in the first two speeches related to lung and cardiovascular, we've heard about reduction of risk factors, so which is the aim of primary prevention. And we have also heard way to early detection of diseases, and I'm talking specifically about the project which was presented by Dr. Apuzzo, but also we've heard about the tertiary prevention into the lung system, thanks to the colleague from Reggio Emilia. All these three aspects together are now ready for your discussion, and any question from the audience will be welcome. And we have also individuals that didn't speak, and we have Lucia Pannese and Ilaria Mariani. And so maybe we can start from them, since you didn't have the opportunity to share your vision in this topic, and so that maybe we're going to have a discussion later on. So please, if you'd like to introduce yourself briefly, and then, go ahead.
Thank you. Can you hear me? Yeah. I'm Lucia Pannese. I'm the managing director of a company called Imaginary, based in Milano, and we're specializing in serious games. These are some examples of the games for health that we develop. So we are not exactly into the medical topic, nor into the topic about elderly people, but we work a lot with colleagues like Ilenia, for example. She mentioned the Don Remi project before. So what we do is using our competence in game design, and I'm talking about games for goals other than entertainment, to prevent diseases, to prevent incidents, to make people, to put them at the center of their health process, health management, so to empower them, as we heard before, or to do some things that have to do with rehabilitation and retraining them to have a normal life. So that will be it from my side for now.
Okay, very good, very good. So any comments on this? I think we'll take this opportunity to address all this technology embedded in the prevention fields. So I'd like to hear from Ilaria Mariani, who's next to me, her introduction, if you want to introduce yourself.
Okay, I'm Ilaria Mariani. I'm finishing my PhD, and I deal with games for change. I know my topic is quite far from the other, because I don't necessarily deal with telemedicine, but with a more direct contact with people. So games to help increasing in general awareness in people and create a critical reflection about sensitive issues. In my research group, we develop different kind of games, from urban to board game or also digital games. And our aim in general is to create, to engage people in a fun way, to engage them in something difficult to speak about, and use this opportunity, the games, as an opportunity to have a critical debate on difficult topics, generally. That's Thanks.
Okay, thank you very much. Now it's time for you from the audience to have questions for the speakers. There's a question just right there. We'll be there. 1 second.
I wanted to ask a question about motivation and participation, because in all of this telemonitoring, I think it's interesting to work out, particularly for long-term conditions, how to maintain the user of the system, the patient, in recording the data. And I just wondered what your experiences were. One, in terms of the pilots that are going on, to what extent do you have dropout, and to what extent do you put effort that goes beyond the normal protocol in order to keep people in the study? Because I think these are interesting measures in terms of the either motivational deficit that there might be in terms of getting these things to work. And I guess Lucia may very well want to say something about motivation in terms of gamification as well. So that was my question.
If I'm able to switch this on.
It's on.
Okay, because it's not blinking. Anyway, so yeah, Stuart, about motivation. First of all, let's say that it's very early stages. So we cannot tell you about experiences of games that have been used for, I don't know, a couple of years, where we can really statistically also observe dropout rates or whatever. So this is the first statement.
Non si sente in cabina.
Ma infatti non riesco a accenderlo. Okay. Sorry, so just maybe for the translation, I was saying that it's very early stages, so we don't have games that have been used for a couple of years or whatever that has a statistical significance so that we can really evaluate data about dropout rates and so on. So this said, we are doing experiments, of course, because one of the main reasons why you use games into all these processes is to motivate people and to, for example, to prevent that they drop out, for example, from long-term rehabilitation, because once the patients are at home, it's getting maybe boring, and they might perceive they're not getting better, while this might even not be true, but they don't know. So they might say, I'm not doing that because anyway it's no use. So one of the things that we do in games is finding a very easy, intuitive way to give a feedback about their process to the user and, of course, the stakeholders, the family, the loved ones, whoever that is, so that they can see, aha, it's useful to do that because I'm better than I was, I don't know, 1 week ago or whatever. And the other topic about motivation, the other aspect is very often we merge the exercises, let's call them like that, with social aspect, so that, for example, either the family, for example, can either play with them or have a role within the therapy and the games, or they can find other people, maybe even people they don't know who have the same problem, so they don't feel alone. They don't feel what happened to me, but the point is us and how are the others doing. So you can challenge someone, you can see the progress of other people, always within privacy, protection and whatever you can think of. And be motivated, because if the others have some progress, then I might as well do better. So these are things that we do into that direction.
Thank you. There's another question there.
So it's a question for Ilaria, I think so. So I am happy to hear that you are investigating about different type of games, not only based on ICT, because I think one of the most issues in elderly people is isolation. And in games, perhaps you can modify this kind of behavior or whatever. And there are some studies that shows the people has big social networking, their outcomes are better than the other. Could you explain a little bit more which are?
Yes. Maybe?
Sure.
Yes. Thank you. I prefer this one to be ice cream. It's better. Yes, it's very important, the cooperation and the collaboration, not to make elderly feel alone. And with some of our games, we try to increase the connection among eldest and youngest. Because, for example, also taking part to the social life and to the institutional life of our country is difficult for someone who doesn't have the access to the information. It's not a lack of abilities, but a lack of tools, of devices, and the ability to use them. So, for example, using games among elderly and young, there could be this intersection and this change and switch of abilities, little abilities. And one of the most important things in games is that sometimes you cannot address games exactly to the person with some disease or problems, but to his relatives. Because sometimes are the relatives who has to be trained, because they can provide help and help people feeling better. Their families can improve the quality of life with just simple kind of tasks during the day, and sometimes game can train you in this direction. Have I answered? Okay.
Yeah, if I can say something, because maybe it's a very simple comment, but there is an evidence base of a huge difference when you have telemonitoring without video conferences and telemonitoring with video conferences. We experimented, for example, in our region, that when people wait for a video conference, they dress, they must dress, they are prepared, they are happy for that, and it is more evidence that they are more involved also in the other aspect of telemonitoring. And when you have only, yes, some devices without any, or some telemonitoring, like traditional one that is, of course, against isolation, loneliness, there is not this way of preparing, being prepared like a visit and so on. But of course, in a general point of view, the ICT doesn't substitute the home visits of social care, family care, voluntary, and so on. Okay.
Good morning. I'm a fitness trainer, and I'm amazed that isn't be touched the argument of physical activity this morning, but I want to make an answer to for the Smart Center Smart project. Okay. In your experience, you have followed a medical fitness project in the region, European region that you have treated, or not?
Okay, no, not officially, but for example, the cardiovascular ward that is in the Trieste Hospital, that is the main center of management of smart care team, it is the base also of the Center for Sports, Medicine, and so on. So we have in parallel some activities for that, but not in in cooperation project.
Okay, thank you.
There's another question there.
Yeah, thank you. I have a question to Gian Matteo and the Smart Care project, which I like very much, although it is once again this disease-oriented approach. Therefore, I would like to ask you, what do you expect from your control group versus versus the project group? Because there it very much depends. You can live, as we also heard from the other presentations, with I think, what is it, coronary heart disease. You have very different people. Some people might live well anyway. The disease as such has nothing to do with their real care needs and with the needs for integrated care, unless you define integrated care as two doctors are talking to each other. So I think here it will very much depend on what indicators will you measure, and what do you expect? What differences do you expect between the two groups? Thank you.
Yeah, thank you, because it's maybe the big challenge that we have, because of course we are aware that when we present the project and we are in the project, there is a focus on telemedicine and on disease because, of course, sometimes it is, the main and the more difficult aspect. No, but of course, I did not present the part of the evaluation, and there is a quantitative evaluation with all the data that are also automatic generated by the system, but we have a very big phase of qualitative evaluation, and we have the social workers that are already involved in the project that are really person-centered worker, and of course we have, I think maybe also too many questionnaires about qualitative data. The point is that at the beginning, when you enroll people, of course, you have to explain very well the aim of the project, but maybe at the beginning, what we are, of course, I'm speaking about Friuli Venezia Giulia, what we are experimenting is, of course, that at the beginning you involve people that you, of course, already know, that have a good attitude on the project, and maybe it is the most difficult to explain for them the exit of the project about a technical aspect. What they really expect is to have a better quality of life, to have, they are really like to be involved in the project. So maybe we are now in the phase where people are enthusiastic to be involved, and maybe we are not still in the phase, we're not yet in the phase where, okay, it's kind of, also the ICT base is a usual care. But I think that is, the point is how you are going to organize the service. And of course, it's not just to go home people and put in some devices and make people stigmatizing with devices, of course, that, okay, you have a disease, you need technical devices. I think that it is very important to involve people, but to involve also informal carers. And also I think that technology is advanced for being less invasive and less stigmatizing. The main goal of the Smart Case is to have quantitative data that maybe is focused on health aspect and disease, but of course qualitative data, and it is really, really focused on quality of life. I don't know if I have answered more or less. Okay, but I know this is the challenge, yes.
There's another question there, the back, please.
Okay, I have a two-part question, one very specific and one more general. So for the one on cardiac care, tool
activity,
not
for methodology.
This is very
is a point, and that to exchange people with the university.
As you see, working to